Hello and welcome to Critical Care MD. My name is Dr. Vikas Koparapu and I am a physician in pulmonary and critical care medicine. My goal with Critical Care MD lectures is to help you understand fundamental concepts of critical care medicine so that you are better prepared for your ICU rotations and you are more confident in caring for the critically ill patients. Today we are going to discuss a very crucial topic of hypotension and shock. Let's start with some practice questions. Let's say you are a resident on general medicine floor service and you get this page at 2 a.m. Patient is a 72-year-old male who is admitted for pneumonia. He has a history of diabetes and CAD. What do you do next? This patient was deemed euvolemic on exam. Over the next 3 hours, he was given multiple 500 cc fluid boluses. Initially, the blood pressure picked up. Later, it did not respond. In fact, started dropping even with fluid boluses. Patient developed new confusion, worsening dyspnea, and had a new oxygen requirement. At this point, he was moved to ICU, had a right IJ central line placed, and central venous pressure was noted to be 14 centimeter water pressure, and central venous oxygen saturation was 55%. What is the most likely etiology of his shock at this point of time? Patient's oxygen needs continued to worsen, and he was ultimately determined to be in cardiogenic shock due to poor LV squeeze function. Vitals are shown on the screen. At this point, what agent would you pick for hemodynamic support for this patient? Think about what option you would pick for each question, and we will discuss the answers at the end of this video. Shock is one of the most important conditions we manage in ICU, and if you become comfortable managing patients in shock and respiratory failure, not only your ICU rotations will become very easy, but also you will be very comfortable in caring for sick patients on the medicine floor. Shock is most commonly recognized in setting of hypotension, so let's develop a systematic approach to a hypotensive patient. When you have a patient with low blood pressure, there are three crucial questions to ask. First is it simple hypotension or is there shock? If there is shock, then it is important to rapidly identify the mechanism of shock, and then only we can come up with appropriate treatment for the shock. Let's start with the first step. Is it hypotension or is there shock? There is no universally accepted standard definition for shock, but the Society of Critical Care Medicine textbook defines shock as inadequate tissue perfusion resulting in cellular injury. Basically, it is a state of deranged metabolism due to global tissue hypoperfusion as opposed to regional hypoperfusion. For example, let's say there is acute thrombosis of an artery supplying a particular limb. There is hypoperfusion to that limb and tissue injury. However, it's not global. So, shock is a state of global tissue hypoperfusion. Recognizing hypoperfusion in setting of hypotension is very important because that constitutes shock and that is a medical emergency. It has to be rapidly treated. Whereas normal perfusion in setting of hypotension is simply low blood pressure or hypotension and that does not need to be treated. Keep in mind that shock can also occur in setting of normal blood pressure. For someone who lives at blood pressure of 120 by 80, 90 by 60 may be low enough to cause shock. But for someone who lives at 170 over 110, a blood pressure of 120 by 80 may be low enough to cause shock. It is very important to be able to recognize signs of hypoperfusion. I recommend a head to toe approach. Start with the head. Hypoperfusion to the brain causes altered mentation, which can range from confusion and agitation all the way to coma. Hypoperfusion to the heart leads to symptoms like chest pain and manifestations like hypotension and tachycardia. Hypoperfusion to the lungs lead to shortness of breath and tachypnea. Start going down. Hypoperfusion to the liver leads to elevation of AST and ALT, the so-called shock liver. However, this may be a late manifestation. Hypoperfusion to the kidneys leads to decrease in urine output, and that's an early sign of kidney injury. There can also be features like electrolyte imbalances and acid-base disturbances, elevation of creatinine, but these are late manifestations, so keep a close watch on the urine output. Hypoperfusion to the muscles leads to disruption of aerobic metabolism, increase in anaerobic metabolism, and elevation of lactic acid. So, this really is the first step. Assess your patient and recognize whether they are in shock or not. Hypotension can exist without any features of shock, and there are several examples for this. Some people just live at a low blood pressure, or it can be drug effect like antihypertensive medications or some of the cardiac medications. Autonomic dysfunction and vasovagal episodes can also lead to hypotension without features of shock, and peripheral vascular disease can also lead to low blood pressure. Once you determine that your patient is in shock, the next important step is to identify the mechanism of shock. There are four mechanisms how shock can develop: hypovolemic, distributive, cardiogenic, and obstructive. To understand these types of shock, we first need to understand the physiology of circulation or hemodynamics. Do you remember the formula V equals IR from your physics class? Basically, what it means is voltage or the potential difference across the battery equals I, which is the current flowing across the circuit, and R, which is resistance of the conductor. Our body works in a similar way. Heart and vasculature is a circuit after all. The voltage or potential difference here is the difference in blood pressure. The chamber of the heart, which receives all the venous blood, is the right atrium. So the pressure on the negative side is right atrial pressure. And the pressure on the positive side, which is the blood coming out of the heart, is mean arterial pressure, the formula for which is two-thirds diastolic plus one-third systolic. It makes sense, right? Because we spend more time in diastole than systole. So we can apply the same formula V equals IR to the vasculature. That translates into voltage is the pressure difference. So difference between MAP and right atrial pressure equals I, or the current, which is the cardiac output that's flowing through the circuit here, and resistance, which is systemic vascular resistance. Normally, if you take a blood pressure of 120 by 80, the MAP will be around 90. And the right atrial pressure under normal circumstances is very low. It's going to be between 0 to 5. So right atrial pressure is kind of negligible if you compare it with MAP. So if you replace RAP with 0 and modify the formula, it will look like this: MAP equals cardiac output, which is stroke volume multiplied by heart rate multiplied by systemic vascular resistance. This is the most important formula we need to remember from a hemodynamic standpoint. Let us see how these physiologic determinants change in each type of shock. Initially, we are going to be focusing on hypovolemic, distributive, and cardiogenic shocks, which together constitute around 98% of the shocks we see in ICU. Also, know that our body has compensatory reflexes in place. For example, if there is decrease in stroke volume for any reason, there is going to be reflex sympathetic stimulation of the heart leading to tachycardia, and reflex sympathetic stimulation of the blood vessels, which leads to vasoconstriction and increase in SVR to maintain the MAP. So change in any one of these determinants leads to increase in the other two to make up for the decrease in MAP. Starting with hypovolemic shock, the main problem here is decreased stroke volume. That's because the heart is not filling up with enough blood. It's not going to squeeze enough blood. So there is decrease in stroke volume and reflex tachycardia and increase in SVR. Moving on to distributive shock, the main problem here is vasodilation. So there is decrease in systemic vascular resistance, and there is going to be reflex sympathetic tachycardia and increase in stroke volume. Moving on to cardiogenic shock, the main problem here is decreased stroke volume because the heart is not squeezing enough blood. There is going to be reflex increase in heart rate and vasoconstriction, which is increased systemic vascular resistance. There is one issue here. Both hypovolemic and cardiogenic shock are looking the same. So just knowing these three determinants is not enough. We need more data to be able to differentiate between all these types of shock. The two extra pieces of information which help us differentiate between different types of shock are preload and central venous oxygen saturation. Let's start with preload. In hypovolemic shock, the predominant problem is decrease in preload, leading to decreased filling of the heart and decreased output. In distributive shock, the preload is generally going to be low. Think of it this way. The water inside the pipes is the same, but the pipes are bigger. There is vasodilation, right? So there is going to be relative hypovolemia in distributive shock. And that's why distributive shocks like sepsis respond well to volume resuscitation. Moving on to cardiogenic shock, the preload is going to be increased because of the elevated filling pressures. Let's talk about central venous oxygen saturation next. Let's go back to the physiology of circulation. The blood that is coming out of the veins is going to be low in oxygen, and that flows through the right heart into the lungs where the blood is fully oxygenated, and that is returned to the left heart, which pumps the blood to the rest of the body. Let's say the blood coming out of the left heart is fully saturated, SpO2 is 100%. What do you think is the oxygen saturation of the blood that is being returned to the heart? The answer is around 70%. Tissues take up only about 25 to 30% of the oxygen they're being supplied with. So our body has a lot of reserve. So the venous oxygen saturation typically is going to be around 70%. Consider a case of cardiogenic shock. Here, the tissues themselves are normal. However, the heart is not pumping blood adequately. So the circulation or the flow of blood through the tissues is going to be very sluggish. The tissues are kind of oxygen deprived, so they are going to extract oxygen vigorously, especially given the circulation is very sluggish. They have more time to take up all the oxygen, so the blood being returned to the heart is going to have low oxygen, typically less than 65%. Let's consider septic shock, which is a type of distributive shock. Here, the heart is normal, it is pumping blood okay, but because of all the inflammation, the mitochondria are damaged. The inflammatory cytokines affect the oxidative phosphorylation. So, even if these tissues are being supplied with oxygen, the tissues don't take them up. So, the blood being returned to the venous side is going to be high in oxygen, usually more than 75%. Another theory that is proposed is normally there are arteriovenous connections which are dormant and don't circulate any blood, but when there is sepsis and inflammation, they open up these abnormal connections which lead to blood bypassing the tissues and directly being returned to the venous side. That's another explanation offered for why the venous oxygen saturation is high in sepsis. Regardless of what theory you pick, the point is in septic shock, the central venous oxygen saturation is going to be very high. Let's understand the difference between mixed and central venous oxygen saturations. Now, all the venous blood is emptied into the right atrium, and that's where the mixing of all the venous blood is happening. For example, from the superior vena cava, inferior vena cava, coronary sinus. So, the best place to obtain venous oxygen saturation is right atrium or distal chambers like right ventricle or pulmonary artery, and that is called mixed venous oxygen saturation. However, to obtain that, we need a right heart catheter or a pulmonary artery catheter. Most patients in ICU are not going to have that. So, the closest alternative we have is a central venous oxygen saturation, which is obtained via a blood sample via right internal jugular central venous line, and that catheter ends close to right atrium. Samples from other sites is not helpful, including femoral venous catheter, which is only giving you information from inferior vena cava. And never use a peripheral venous oxygen sample because these samples are not indicative of the global perfusion. So, again, mixed would be ideal, central would be an alternative. Identifying these five important determinants will help you determine the mechanism of pretty much any type of shock in ICU. Keep in mind that sometimes there will be a mixed picture. There may be more than one types of shock, or even in one type of shock, these determinants may change. For example, early on in distributive shock, there will be vasodilation, but in a late stage, there can be severe sympathetic stimulation and vasoconstriction and increase in SVR. Nevertheless, identifying all these pieces of information and putting them together will help you identify the most important mechanism or physiology that is contributing to the shock. All this data can be easily identified or estimated. For example, heart rate needs a simple physical exam, and using tools like telemetry and ECG, we can even get this data retrospectively. Pulse pressure, which is the difference between systolic and diastolic blood pressures, is considered a surrogate for stroke volume. So, lower pulse pressure means lower stroke volume. But a more reliable way of knowing stroke volume is point of care ultrasound exam. Looking at the subjective squeeze of the LV, is it hyperdynamic or is it hypocontractile, can help you kind of estimate the stroke volume. LVOT VTI is a more advanced point of care ultrasound assessment which will help you actually calculate the stroke volume. Systemic vascular resistance can be identified by simple physical exam. Feel the extremities. If they are warm, it usually means a vasodilated state. Cool and clammy extremities indicate a vasoconstricted state or increased systemic vascular resistance. Now, feel at the level of wrist or ankles or more proximally, because if you feel the extreme toes and fingertips, they may always be cold for some patients. Also, look at capillary refill time. If it's under 3 seconds, that's normal or indicates a vasodilated state. If it's really prolonged, that goes with a vasoconstricted state. Preload can be estimated by simple physical exam. Look at JVD. If there is a central line, you can also get a central venous pressure. Look for S3 bibasal crackles, peripheral pitting pedal edema or peripheral pitting edema. All of these can be helpful to estimate the preload. Point of care ultrasound can also be very useful here. You can look at the IVC diameter and collapsibility. Using all this information, make a best estimate of patient's preload. Is it euvolemic, hypervolemic, or hypovolemic? Central venous oxygen saturation may not be available for every patient because it needs a central line, but that's strictly not necessary. If you have the other four pieces of information, that should be enough. There is one special circumstance though. If there are features of both cardiogenic and distributive shock, SCVO2 can be very helpful because it goes in the opposite directions for these two types of shock. So very low SCVO2 goes with cardiogenic, very high goes with septic or distributive shock. As discussed, point of care ultrasound has a very important role in shock. Not only is it helpful for evaluation of preload and stroke volume, it can also be very useful for evaluation of obstructive shock. Pulmonary embolism is a major cause of obstructive shock, and identifying RV dysfunction can be very helpful here. There are other reasons beyond PE for RV dysfunction, so it is not very specific. But when RV is normal, that's where this can be useful. For example, you have a patient who is in shock and you look at their RV with POCUS and it's looking normal, then the cause of shock being PE is very, very unlikely. Cardiac tamponade is another cause of obstructive shock, and POCUS can help us recognize pericardial effusion. And also, using some advanced measurements, we can also recognize if there is hemodynamic significance of the effusion. And using point of care ultrasound, we can also look at signs indicative of pneumothorax. Finally, POCUS can also be useful in identifying regional wall motion abnormalities. If you have a patient who is admitted for cardiogenic shock and you identify regional wall motion abnormalities with POCUS, then the chance of coronary artery disease as the cause of cardiogenic shock is very high, and patient needs urgent evaluation for coronary occlusion. We are not going to go into the details of point of care ultrasound in this video, but in future I do plan to make a video on point of care ultrasound, so make sure to subscribe for such content in the future. A more direct assessment of these hemodynamic parameters can be done via right heart catheterization. This will give you quantitative, unambiguous information about indices like stroke volume, SVR, preload, and mixed venous oxygen saturation. While this may look attractive, we don't generally use right heart catheters in patients with shock for one simple reason. Large studies have failed to show any significant improvement in outcomes when right heart catheter is used. And also, there are complications that come with the procedure and the catheter. However, it still has its role. We sometimes use it to diagnose the mechanism of shock when it is unclear with less invasive measures. And it can also be used to assess response to treatment, particularly used in cardiac ICU. It is very important to first identify the mechanism of shock and then only look for etiology of shock. Take, for example, a 71-year-old male with history of CAD who is admitted for pneumonia. 2 days later has developed worsening hypotension, shock, and is being transferred to ICU. One may say this patient was admitted for pneumonia, this is septic shock. No, just because patient has pneumonia doesn't make him immune to having a massive myocardial infarction and developing cardiogenic shock. If you look at the treatment of shock, for example, cardiogenic shock, it is treated with diuresis, not fluids. Other two shocks are treated with fluids. If you use a pure arterial vasoconstrictor without inotropic properties, that may be deleterious in cardiogenic shock because we are increasing the afterload, whereas a vasopressor may be the right choice in septic shock or volume resuscitated hypovolemic shock. So some of these treatments are in the opposite direction. So if we don't identify the mechanism and empirically treat every patient with fluids and random vasopressors, we may actually end up harming the patient. So that's why it's crucial to first assess the hemodynamics and make a diagnosis of the mechanism of shock before proceeding to etiologic evaluation. Coming to etiology, there are a long list of causes. It is useful to categorize each type of shock into subtypes when approaching etiology of shock. Let's start with hypovolemic shock. It can be of two types, hemorrhagic or non-hemorrhagic. Hemorrhagic in turn can be either external or internal. Distributive shock can be of two types, septic, which is the most common type of shock in ICU, and non-septic. Non-septic can be from multiple different reasons, including SIRS response, neurogenic, anaphylactic, or certain cases like drug overdoses, adrenal insufficiency, etc. When we say cardiogenic shock, we typically refer to pump failure where LV is not squeezing adequately, but there are two other categories of cardiogenic shock. One is arrhythmogenic, so extreme tachycardia and bradycardia can lead to cardiogenic shock, and it can also be mechanical. Examples would be acute valve rupture, ventricular septal defect, ventricular free wall rupture. It is very rare to see these causes in the post PCI era. Obstructive shock, or more specifically extracardiac obstructive shock, can be two types. It can be from acute RV failure, pulmonary embolism being the big example here, or it can be also mechanical from extracardiac obstruction like cardiac tamponade, tension pneumothorax, and certain other conditions. So, step one was recognition of shock in a hypotensive patient. Step two was identifying the mechanism of shock. And now we come to step three, which is management of shock. For most conditions in ICU, we have two roles. One, we have to provide supportive care, and two, we have to treat underlying cause. This applies to shock, this applies to respiratory failure, this applies to AKI and renal failure, it applies to multiple conditions in ICU. Timely provision of supportive care is essential for shock management because early on the tissue injury from shock is reversible with adequate treatment, but delay in diagnosis and especially treatment can lead to irreversible organ damage and death. As far as supportive care for shock is concerned, there are three things we can do. One, we can adjust preload, usually involves giving fluid to augment the preload, rarely giving diuresis to decrease preload in a patient with cardiogenic shock. Second, we can use agents to increase cardiac contractility or heart rate, or we can adjust vascular tone by using agents that increase vasoconstriction. Fluids are the initial agents of choice for resuscitation, and pretty much any form of shock responds to fluids, cardiogenic shock included. Let's talk a little more about that. If you take any patient, unless they are extremely hypovolemic, and give them massive amounts of fluids, let's say 6 liters or 8 liters, within a couple of hours, most patients are going to develop pulmonary edema. It's just that in a patient who is in cardiogenic shock, that is going to happen much earlier as little as 1 liter may be enough to push them into florid pulmonary edema. So, if a patient in cardiogenic shock is not in pulmonary edema, not in respiratory failure, not needing supplemental oxygen, you can still use fluids and there may be a response. Usually, I recommend using small boluses like 250 cc or 500 cc, closely assess the patient, and repeat as needed. Usually, by the time we get paged in ICU to see these patients, they have already gotten enough fluids and they're already showing signs of pulmonary edema. So, we usually diurese these patients in ICU, but I just want to emphasize the point that cardiogenic shock is not an absolute contraindication to using fluids. We have a few choices when it comes to fluids. Broadly, based on the size of the solute, they are categorized into colloids and crystalloids. Crystalloids are the agents of choice because colloids, for the most part, studies have shown no clear benefit compared to crystalloids. Colloids are expensive, there is potential for allergic reactions, and also there's potential harm in capillary leak syndromes. For example, when there is intense inflammation like ARDS or severe sepsis, there may be capillary leak, and these large molecules may escape into the interstitium and cause edema. So, colloids are generally not preferred. Within crystalloids, broadly, there are two categories. There are unbalanced fluids, mainly normal saline, and balanced fluids, also called buffered fluids. The main difference is that balanced fluids have a chemical composition that closely resembles plasma. For example, normal saline has much higher levels of chlorine or chloride compared to normal plasma levels, whereas the levels of sodium, potassium, and chloride in lactated ringers closely resembles that of plasma. Normal saline is probably the most popular fluid used for resuscitation. One major disadvantage is that due to high chloride content, it is associated with non-anion gap metabolic acidosis. With lactated ringers, obviously the risk of metabolic acidosis is low compared to saline, and some studies have even shown potential mortality benefit in septic shock when LR is used for resuscitation. Due to these reasons, LR is becoming the more preferred agent for volume resuscitation, especially when more than 2 liters are needed. It is not without risks though, because lactated ringers is a slightly hypotonic fluids. There is a theoretic risk for hyponatremia when excess amounts of fluid are used. Also, it does have potassium in it, so there is risk for hyperkalemia, though this claim has not been substantiated in studies. Couple of things to keep in mind. Dextrose in the fluids is rapidly metabolized and it does not hold fluid within the intravascular component. So don't use dextrose containing fluids unless there is other indication to use them. Also, be liberal with using blood products for volume resuscitation in a patient with hemorrhagic shock. How much fluids to give for volume resuscitation is a $1 million question in ICU, and no matter how much you read, you are not going to get a straightforward answer to this question. And the reason for that is every patient's intravascular volume status is going to be different, and every patient's tolerance to fluids is going to be different. For example, an 80-year-old patient who has CHF and ESRD may not tolerate much fluids, may start showing signs of pulmonary edema within the first 1 to 2 liters, whereas a young patient with healthy heart who is admitted for hypovolemia may tolerate 6 liters of fluids or more before showing signs of pulmonary edema. So, one size does not fit all. Here is my recommendation: assess two things which will help you make a decision. First, understand the volume status of the patient. Traditional indicators of volume status are JVD, central venous pressure, bibasal crackles, S3, skin turgor, mucous membranes, peripheral pitting edema, and all of these. In the recent years, more emphasis is being laid on novel predictors or so-called dynamic predictors of volume responsiveness, mainly IVC collapsibility. Now, discussion about other dynamic predictors like pulse pressure variation, stroke volume variation, passive straight leg raise test, or even IVC collapsibility for that matter. These are all a discussion for another day, but the take home point is do a thorough assessment and make a best estimate of what the volume status of the patient is. Is the patient euvolemic, hypo, or hypervolemic? Then look at the perfusion status, things we already discussed. Do a head to toe assessment and understand the perfusion status of the organs. Now, some people like to use urine sodium as well to assess perfusion of the kidneys in hypovolemic patients. The rationale is that if kidneys are not getting enough blood supply, they sense that and they try to conserve sodium to preserve intravascular volume. So a urine sodium of 15 milliequivalents per liter is considered the cutoff. So some people give fluids until urine sodium reaches beyond 15 milliequivalents per liter, but this does not apply to patients with CHF and cirrhosis and conditions like that where intravascular volume can be low but overall volume is up because of interstitial edema. Anyways, that's not something we commonly use, but some people do like to use urine sodium. So understand these two situations: what is the volume status of the patient and what is the perfusion status, and keep giving fluid boluses, 500 cc or 1 liter boluses, until there is refractoriness, meaning more fluids are not translating into increased blood pressure, or until there is intolerance, meaning you are seeing clear signs of volume overload, especially pulmonary edema, or in fact the blood pressure is dropping with more fluids. So keep giving fluids while closely assessing the patient for these harmful effects of excessive fluids. In sepsis, 30 cc per kilogram body weight is recommended as the initial guideline or initial amount of fluids within the first 3 hours. This is also extrapolated to hypovolemic patients, but again, this is a rough number. Some patients need more than that, some patients need less than that. The key point is give small boluses, or even 500 to 1 liter boluses. Closely assess the patient before deciding if more boluses are needed. Like I said, closely monitor patients for hypervolemia and be cautious in patients with respiratory failure, CHF, and kidney disease. In patients who are intolerant of fluids or are refractory to fluids, the mainstay of supportive care is vasopressors and inotropes. Sometimes the word vasopressor is used to cover both inotropes and vasopressors, but in my opinion, they should be kept separate. A vasopressor is something that causes vasoconstriction, and inotrope is something that increases the contractility of the heart. Sometimes the word vasoactive agent is also used to cover these agents. Let's look at the mechanism of action of commonly used vasopressors and inotropes in ICU, starting with norepinephrine, also known as Levophed. It mainly acts on beta 1 receptors, which are located in the heart, and alpha 1 receptors, which are located in the vasculature. It has no beta 2 action. So, beta 1 stimulation causes increase in contractility or inotropy and also can increase the heart rate or chronotropy, whereas alpha 1 stimulation leads to vasoconstriction. Now, keep in mind that any agent that causes vasoconstriction can lead to reflex bradycardia, and any agent that leads to vasodilation can lead to reflex tachycardia due to reflex sympathetic responses. So, the net effect of using norepinephrine is increase in stroke volume due to inotropy and increase in systemic vascular resistance due to vasoconstriction. Often the heart rate is not affected because there are opposing effects, right? With beta 1, it is trying to increase heart rate, but due to vasoconstriction and reflex bradycardia, it is trying to decrease the heart rate. So main effects of norepinephrine again are increase in stroke volume and SVR. Moving on to epinephrine. It acts on all the adrenergic receptors, beta 1, beta 2, and alpha 1. The net effect is it increases heart rate, it increases stroke volume. As far as systemic vascular resistance goes, it is variable because it is acting on both alpha 1 receptors, which cause vasoconstriction, and beta 2, which cause vasodilation. So, usually at lower doses, beta 2 predominates and there can be vasodilation, but at higher doses, there's going to be vasoconstriction. Moving on to dopamine, it is an interesting agent, and the degree of receptor stimulation is dependent on the dose. And not only adrenergic receptors, dopamine also acts on its own receptors called dopamine receptors. The net effect of dopamine is really dependent on the dose, but at lower doses, it primarily acts on dopamine receptors, causes renal and splanchnic vasodilation. At higher, or let's say at moderate doses, it increases heart rate and stroke volume. At higher doses, typically more than 10 micrograms per kilogram per minute, alpha 1 effect predominates and it causes vasoconstriction. So the net effects of dopamine are increase in heart rate, stroke volume, and SVR. So SVR usually goes up with higher doses. Compared to norepinephrine, dopamine has a high chance of causing tachyarrhythmias. Moving on to dobutamine, it predominantly acts on cardiac receptors beta 1 and beta 2. So, by beta 1 stimulation, it increases inotropy and chronotropy. By beta 2 stimulation, it's actually located on the vasculature, it leads to vasodilation. Dobutamine has no effect on alpha receptors, so there is unopposed vasodilation. Net effects with dobutamine are increase in heart rate and increase in stroke volume. SVR actually decreases with dobutamine. So a couple of things to keep in mind are it's a good agent for cardiogenic shock because it's an inotropic agent. It also causes vasodilation and decreases afterload. But at the same time, the problem with that is it may sometimes cause more hypotension. So that's one problem with dobutamine. Phenylephrine purely acts on alpha 1 receptors, so it causes vasoconstriction. Net effects are it increases SVR, and due to reflex bradycardia, it can lead to decreased heart rate. Stroke volume is usually not affected, especially in patients with healthy heart. But in patients with systolic dysfunction, be cautious with using agents like phenylephrine because you're increasing the afterload that can further worsen cardiac function. Vasopressin acts on V1 receptors on vasculature and causes vasoconstriction. So, similar to phenylephrine, it causes elevation in SVR and bradycardia. Milrinone works via phosphodiesterase inhibition. It acts on both venous system, arterial system, and the heart. So, its net effects are it causes venodilation and arterial dilation, basically decreases preload and afterload, or in this case, let's say it decreases the SVR. At the level of heart, it increases cardiac contractility. Its effect on heart rate is not potent like dobutamine or dopamine, so it generally doesn't cause tachycardia. But due to inotropy and vasodilation, and also decreased preload due to venodilation, milrinone is a good agent for cardiogenic shock. Usually, it is a second line agent, though dobutamine is often preferred. Let's understand the role and application of each of these agents in ICU. Except for vasopressin, all of these agents come with a titratable dosing range. The way we adjust the dosing is we pick a goal map, usually 60 or 65 millimeters of mercury, and when available, we take other indices of perfusion into consideration, like hourly urine output, central venous oxygen saturation, cardiac index in patients with right heart catheterization, all of these into consideration when adjusting the goal map. Starting with levofed or norepinephrine, it is probably the most popular and most commonly used agent in ICU. It has excellent safety profile. It is the agent of choice for septic shock, and it works for pretty much any other form of shock. Excuse me. So if you don't know the type of shock and if you want to use levofed for support, you won't be wrong. Moving on to epinephrine, it is the agent of choice for anaphylactic shock, and it is also commonly used as a second line or add-on agent for septic shock. Sometimes during emergencies, you can also dilute it and give as bolus dosing. The regimen for dilution is given on the screen. The main risks with epinephrine are tachyarrhythmias due to intense beta 1 stimulation and also lactic acidosis. This happens via aerobic glycolysis in the skeletal muscle induced by epinephrine. Moving on to dopamine, excuse me, because at low doses, dopamine causes renal vasodilation. Several years ago, it was used for the purpose of renal protection, but subsequent studies have not shown that to be true. Patients who get dopamine don't have less kidney injury or less need for renal replacement therapy. So, dopamine should not be used for that purpose. It is usually an alternative for septic shock if norepinephrine is not available. Dopamine is notorious for causing tachyarrhythmias, things like frequent PVCs, atrial tachycardias. All of these are common with dopamine. Also, there is higher risk for mesenteric ischemia compared to norepinephrine due to splanchnic vasoconstriction. Moving on to dobutamine. It is the agent of choice for cardiogenic shock because it has inotropic properties and it causes vasodilation, so it is decreasing the afterload. But one problem with that is it causes hypotension due to arterial vasodilation. So, in patients who have low blood pressure in setting of cardiogenic shock, dobutamine is frequently used in combination with norepinephrine to prevent vasodilation. Dobutamine can also cause tachyarrhythmias, and this side effect of dopamine, and epinephrine can be put to use in patients with bradyarrhythmias. So, if the purpose is to increase the heart rate, these three would be good agents. Moving on, vasopressin. It is a pure arterial vasoconstrictor. It is used as a second line for septic shock after norepinephrine. It is used as a fixed dose. Couple of risks to keep in mind. There can be cardiac dysfunction. Any agent that causes vasoconstriction increases afterload, right? So in a failing heart, that's not good. So be cautious in patients with cardiac dysfunction. There's also risk for hypotension following withdrawal of vasopressin. So if patient is on both vasopressin and levofed, we turn off vasopressin first, followed by gradual titration of levofed. Moving on to phenylephrine, it is not very commonly used in ICU. It is considered a third line agent for septic shock, excuse me, after levofed plus epinephrine or levofed plus vasopressin. It would be preferred when tachyarrhythmias are a concern because it causes vasoconstriction and reflex bradycardia, so relative reduction in heart rate. So it can be used for that purpose. It is also one of the agents that can be used as IV push bolus dosing in emergencies. Like, let's say patient just got sedation for intubation and after that blood pressure suddenly dropped, you can use phenylephrine for IV push bolus dosing. And just like vasopressin, there is risk for cardiac dysfunction due to arterial vasoconstriction. Milrinone, it is used as generally a second line agent or an alternative to dobutamine for cardiogenic shock. Don't use it for other forms of shock. Main risks are hypotension again because it causes vasodilation. Milrinone also needs dose adjustment in renal dysfunction. It can also cause tachycardia, but in general, the risk for tachyarrhythmias is lesser compared to dobutamine. There are some advanced invasive forms of support available for cardiogenic shock, especially when that occurs in setting of acute myocardial infarction and is refractory to medical management. These are some complex devices used in cardiac ICU. We almost never see them in a regular medical ICU. As we previously discussed, cardiogenic shock can also occur with extreme tachycardia and bradycardia, and it's not always from pump failure. It is important to be able to recognize these extreme arrhythmias and follow appropriate ACLS algorithm. Bradycardia, for example, when it's associated with shock, it needs to be treated with atropine. Sometimes that's not enough, and patients need continuous infusion with either dopamine or epinephrine to maintain the heart rate. And at that point, we also need to consider calling cardiology and pacing, either external or transvenous, to support the heart rate. The most important step for Extreme tachycardia associated with shock is synchronized cardioversion. While supportive care is being provided to maintain tissue perfusion, every attempt must be made to identify and treat the underlying cause of shock. There are a long list of causes for shock, and discussion of the treatment of every single cause listed here is way beyond the scope of this lecture. But let's quickly go through some emergencies. Hemorrhage must be promptly recognized and stopped. Sometimes it needs surgery, sometimes it needs embolization of the bleeding blood vessel by IR, sometimes it needs endoscopy, for example, in upper GI bleeding. Prompt administration of antibiotics is essential for septic shock. So is giving epinephrine for anaphylactic shock. Myocardial infarction and coronary artery disease are the leading killer in the US and in several other countries like India. So the way death occurs in coronary artery disease is cardiogenic shock. That's the final common pathway leading to death. So we need to be very vigilant in cardiogenic shock and look for underlying cardiac ischemia. And if that's a concern, patient needs immediate evaluation for revascularization. And unstable arrhythmias need to be promptly treated by either cardioversion or atropine or interventions like pacing. Obstructive shock is also usually an emergency. If it's pulmonary embolism, it needs prompt tissue plasminogen activator or thrombolysis. If it is from cardiac tamponade or tension pneumothorax, it needs immediate evacuation of the fluid and air, respectively. Here is a quick summary of our discussion. Always begin with assessment of the patient to differentiate simple hypotension from shock. Then do a rapid assessment to identify the mechanism of shock. Then provide appropriate supportive care depending on the mechanism of shock, while simultaneously looking for the causes and treating the underlying cause with particular attention to certain emergencies. Now let's move on to practice questions and conclude this topic. The first question was getting paged about a patient with low blood pressure. As we discussed multiple times now, the first step is assessing the patient. Other options here may also be appropriate, but none of them replaces immediate assessment of the patient. So right answer here is C. Question number 2. Patient was deemed euvolemic on initial exam and was given multiple fluid boluses over the next few hours. Initially, there was improvement in blood pressure, then it started to drop. And not only that, patient developed new confusion, worsening shortness of breath, and increasing oxygen need. So there is evidence of worsening shock. Right IJ central line was placed and CBP is elevated and central venous oxygen saturation is pretty low. Putting all of this together, at this point of time, the most likely etiology is cardiogenic shock. Remember, in cardiogenic shock, central venous oxygen saturation is going to be low, whereas in septic shock, it is going to be high. Patient was transferred to ICU and placed on high flow oxygen, determined to be in cardiogenic shock with an ejection fraction of 20%. Vitals show he is still hypotensive despite all those fluid boluses and is also needing a lot of oxygen. What is the best agent to use to provide hemodynamic support for this patient? So you don't want to use vasopressin or phenylephrine here. Increasing afterload without providing inotropy is not good. So C and D are ruled out. Between dobutamine and dopamine, I would pick dopamine. Why? Because patient has low blood pressure already, and if we start dobutamine without providing concomitant levofed or norepinephrine, high chance that blood pressure is going to further drop. So while dobutamine is not necessarily a wrong option here, dopamine would be more appropriate. That concludes today's discussion. I hope you found this video helpful. If you did, please support my channel by clicking on the like and subscribe buttons. Also, share it with someone who you think will benefit from this lecture. Finally, I would love to hear your thoughts. Is there any part of this video you found particularly helpful? Is there anything I could have added to make this video more useful to you? And what topics would you like to see me discuss in the future? Do leave a comment and I will see you in the next video.